Hey everyone. Today we're diving into chest radiography, which is basically taking X-ray pictures of your chest. Chest radiography uses X-rays to create images of the chest area for medical diagnosis. We'll focus on the key anatomical areas that appear on these images. First, the bony thorax includes the ribs and spine, which provide the structural framework of the chest. Understanding these structures helps in interpreting X-rays. Next, the respiratory system consists of the lungs and airways, where gas exchange occurs. These are crucial areas to evaluate on chest X-rays. The mediastinum is the central space containing the heart and major blood vessels. For proper positioning, we use landmarks like the vertebra prominence at the base of the neck and the jugular notch at the top of the sternum. Getting the right position is important for clear images. Remember, chest X-rays show the bony thorax, respiratory system, and mediastinum, and proper positioning using landmarks ensures clear images. Now let's talk tech. Key factors influence image quality in chest radiography. First, kilovoltage peak, or kVp. We typically use high kVp between 110 and 125 kilovolts to produce a long-scale contrast image, meaning we can see a wide range of tissue densities. Second, source-to-image distance, or SIDE. A 72-inch SID is used to minimize magnification of the heart, giving us a more accurate representation of the anatomy. And third, the breathing technique. We take the exposure on the second full inspiration. Why? Because this maximizes lung aeration, helping us see subtle details that might be missed otherwise. Get these factors right. High kVp for contrast, proper SID for accuracy, and second inspiration for detail, and you're well on your way to diagnostic images. Time for some practical projections. The most common is the postero-anterior view, or PA for short. In this view, the patient stands facing the X-ray plate, with the X-ray beam coming from behind them. This gives us a clear frontal view of the chest. Next, we have the lateral view, which gives us a side-on perspective. The patient turns sideways to the plate, with the beam coming from the side. This helps us see the depth of structures in the chest. Oblique views are angled projections that can highlight specific areas of the chest. The patient rotates at an angle, usually 45 degrees, to show structures that might be obscured in standard views. For the upper airway, we use dedicated views to examine the trachea and surrounding structures. This might involve a different positioning or collimation to focus on the neck and upper chest region. Each projection has specific evaluation criteria that we check to ensure the image is technically adequate. For example, can we see all the ribs? Is the trachea midline? Are vertebral bodies visible? Remember, image quality is key for accurate diagnosis. One size doesn't fit all when it comes to chest radiography. We need to adapt our techniques for different patient groups to ensure the best possible imaging while keeping radiation exposure as low as reasonably achievable. Let's start with pediatric patients. Children are more sensitive to radiation, so we use lower doses and shorter exposure times. This helps protect their developing tissues while still getting clear images. For geriatric patients, mobility limitations are common. We might need to adjust positioning to accommodate reduced flexibility or use supportive aids. The goal is to ensure patient comfort and stability during the examination. When imaging obese patients, we often need to increase the kVp to penetrate the thicker tissue layers effectively. This adjustment helps maintain image quality without compromising diagnostic value. The key takeaways here are that we must adapt our techniques based on patient factors, always balancing optimal image quality with minimizing radiation exposure, and remembering that each patient group requires thoughtful consideration for the best outcomes. Let's connect what we see on the X-ray with clinical conditions. Pneumonia might appear as consolidation or opacities in the lungs. A pneumothorax, or collapsed lung, will show a dark area where the lung should be, with absence of lung markings. Pleural effusion, or fluid in the pleural space, will look like a blunting of the costophrenic angle.